Thank you and good morning. I'm excited to be here today, and my flight issues were certainly a worry of mine. I didn't think I was going to make it actually, and God knows what I'll say after a 15-hour flight, so bear with me. As I thought about the forum and as I thought about what I would bring and talk to you about, I thought about your theme of making change happen. And I figured, what can I talk to you about that could really impact or affect change? I can certainly talk to you about electronic health records and informatics and technology and implementations, but I figured that a better theme or a better talk would be to bring the voice of the patient to us, and why it's so important that we engage our patients as equal partners if we really want to affect and impact the care that we provide. So I want to share that voice with you as I move along. In 2001, the Institute of Medicine came out with their landmark report on the state of healthcare. And in that report, they came out with a number of recommendations. One of those recommendations was really around the importance of delivering patient-centered care and the focus on that. And that was in 2001. The Pickering Institute and the Harvard School of Medicine identified 8 principles of patient-centered care that are listed here. And as you read them, you look at them and you say, yeah, that makes sense. Why aren't we doing it, right? I've been a part of Elsevier for 11 and a half years, bringing evidence-based solutions to the bedside. Our primary objective is to take that scientific knowledge that's published, that best practice, and bring it in a consumable way to the clinicians at the bedside so that they can use that information to deliver better care. That's our main focus. In order to do that, we've adopted a definition of evidence-based practice, and we use Sackett's definition. And when I work with clients, I work with them on ensuring that they adopt a definition of evidence-based practice if they really want to have a culture around that. But the definition is these 3 items, these 3 things, these 3 components. It's best research, it's clinical expertise, and it's patient values. Again, the importance of bringing the patient in as we're working with them, and working with them to really develop a care plan or a plan of care that really meets their needs, and that's individualized and personalized. And I'm sure you've heard all these terms because they've become pretty much buzzwords lately, and almost have a negative connotation when it comes to them. So this is what we have today. And I ask myself, why is it such a challenge to have a delivery model that's centered on the patient, right? In fact, a couple of studies have been done that show, and I don't want to pick on our physician colleagues, but it's a nursing forum, let's do it, right? Some of these studies showed that on average, patients weren't even able to complete their opening remarks without being interrupted. Only 23% of the time they were able to complete their opening statements. On average, they were interrupted at 18 seconds. So imagine how much information you can provide your physician within 18 seconds without being interrupted. Another study showed that on average, patients were being interrupted every 12 seconds before completing the information that they were pushing out, and that females are interrupted even more. So it's pretty sad, right? And I would say that this is not only the physicians, but also any one of us disciplines who are caring for the patients, that we tend to do the same thing and not really listen to our patients and what they have to say. I like this quote by Robert Frost, right? And it really is about that duh moment, right? Something that is so obvious that you hit yourself on the forehead and say, my goodness, what was I thinking? I call these epiphanies for me. I like that word a little bit better than the duh. And I want to share some of my epiphanies that I've had in my career that have really made me change the way that I practice and how I work with patients. But before I do that, I want to ask you to reserve judgment on my epiphanies. Some of you may have had these and may have think, well, what's so inspiring about this? So keep in mind that, I wasn't born to be, I'm not perfect. I was only born to be awesome, as nurses are. So my first epiphany, I started working as a critical care nurse right out of nursing school. I started in a cardiothoracic intensive care unit. And we that go into that area of care tend to have a slightly different persona, right? We like to be in control. We certainly like and are stimulated by that adrenaline, right, of stressful situations and working with highly complex patients. And in fact, for me, the more complex the patient was, the more drips they had. If they were ventilated, if they were sedated, and if they had a swan, that was my patient that I wanted to take care of, right? Very complex. So I remember taking care of this one patient, lady, one day. I got the report, and she was vented, paralyzed, sedated, swanned, and had about 7 different drips going. So pretty sick, pretty complex. And I started working. About 2.5 hours after starting, I stood at the foot of her bed, and I said, wow, she looks great. Every line is in position, every line is labeled, she's stable, her sheets are nice and crisp, she's white, she's great. She looks fantastic. And I said to myself, wow, I'm such a good nurse. And then immediately, it was like a thunderclap, like that slap in the forehead. I thought, wait a second. Not once during this whole entire time did you talk to her. Did you prepare her for what you were doing? That you treated her like a human being and not like a task. You're not such a great nurse. Right there and then, I was appalled and I made a change, right? My second epiphany was a little more emotional one. I was taking care of a patient. He was in his early 50s, and unfortunately, he became so sick that there was nothing we can do. He was on many medications to keep him alive, and the family decided that they wanted to let him go, basically. So the doctor came and said to me, when the family comes to the bedside, turn all the IV drips off, and let's just let him go. So the family came, and I turned off the medications, and the family began to say their goodbye. Now, I stood there with them, trying to support them as best I could, and this saying is so true. I could hardly breathe because it was so emotional. His wife was just amazing. She kept comforting him and telling him that it was okay, that they were going to be fine, and that it was a beautiful day for him to go to heaven. And I can still remember the sky, because she kept saying, the sky is blue and it's perfect for you to go. And she comforted him. And she came up to me and comforted me as well. And from that I learned, the importance that it's not just about the patient, but it's really about the family. And sometimes there is a goodbye. Several months later, I took care of a patient who also was dying. And unfortunately, he didn't have anyone with him. So I stood there with him, and I helped and said goodbye. Now, you may think to yourself, he passed away. What good did you do? I certainly felt better as a clinician doing that for him because he was all alone. We lost my grandfather about 20 years ago. And if you ask any one of my family, their biggest regret was that he died by himself. We were not there with him when he passed away. So don't underestimate the importance of those interventions that we do as clinicians as we're taking care of our patients and saying goodbye. My third epiphany that I'll share with you, I've had many, but one that I will share with you. I was taking care of a gentleman that came back to the unit for a cardioversion, big guy. And we had an open unit then. So basically he can hear and see everything around them. And as you know, critical care units, especially CTICUs, tend to be very noisy. I walked in front of him and I noticed that his heart rate was up and that he was just pale and had the look in his eyes that he was so afraid, right? The look of terror. And I did something that I had never done before. I sat on his bed, and I took his hand, and I held it. And I explained to him what was going to happen, and I also said to him, don't worry, I'm going to be here with you. Everything's going to be fine. Now, I didn't think anything more of it until after the procedure and after we were going to send him up to the floor. And his son came to me and said, I want to thank you for what you did for my father. And I looked at him like, what? And he said, my father told me what you said to him, and it meant so much to him, and I want to thank you for what you did. And I said, you don't have to thank me. That's what we do as nurses. That's what I'm supposed to do. And he said, no, you've done so much more. So these moments, come to us, and what I will say to you is that we've all had them, and that we need to look at those stories and those experiences to really help us change the way that we approach our patients. I'm lucky to work for an organization that really values what we learn from our patients. At Elsevier, we follow patients and their stories for years at times to learn from them and those experiences. And it's really important because the patient's story is powerful. In fact, the Mayo Institute back in the States will say to you that the most powerful diagnostic tool that's available to them is a complete patient history, a thorough patient history. It's not the labs, it's not the diagnostic tests, et cetera. It's that patient story, that information that patient is providing. So I want to share with you another patient story. This is Rosa. Rosa is 90 years old. She's a widow, and she lives with her daughters. She has 4 children, 12 grandchildren, 20 great-grandchildren, and 3 great-grandchildren at that point. Rosa became pretty sick. She has a complex medical history. At 90, she has heart failure, she has COPD, and she has diabetes. And she developed pneumonia and got fluid overloaded and anemia and was admitted to the hospital. From a care planning perspective, being a nurse, right? You look at all of her diagnoses and all her conditions, and she has about 23 problems that we would need to look for to prevent or manage as we're taking care of Rosa. So a pretty complex case. Out of those 23 problems, 9 were actual problems that were being managed as she was admitted during that stay. But even before Rosa came to the hospital, she was at risk once she got admitted. Evidence shows that patients will develop functional deficits right away, 2 days post-admission. And that for a geriatric patient, that functional deficit can lead up to 3, it could take 3 months for them to recover from those deficits, from not ambulating, not walking those patients. And by not doing that, she's at risk for a different set of problems that are listed here. So this is without her even having her problems. She's at risk by just coming and being admitted if we don't think about it in those ways. What else do we know? We know that we have a huge problem with adverse events. I mean, that's across the globe. I get the chance to talk to hospitals all over the globe, and we have the same issues. We do cause unintentional harm to our patients, right? There's different types of errors that causes adverse events. One of them are those errors of omission. That's when we forget to do something. We forget to do an intervention that would be appropriate, or we don't do an intervention that's appropriate. In fact, some of the studies that have show you that these are the 9 most frequently missed interventions that we don't do for our patients. Ambulating our patients is one of the most missed interventions. So now we know this. So with Rosa and her condition, the medical plan for her was that they were basically going to give her comfort care, send her home with hospice, and let her go. She was very, very, very sick, and from a medical perspective, they said, it's time for her to go. And they spent their time focused on that, on letting her go, and talking to the family about that. Now, Rosa's plan was slightly different. Rosa wanted to go get out of bed She wanted to go home. She wanted to be able to bathe herself. She wanted to go back to what she was doing. That was her plan. Whose plan do you think won? Which plan was implemented? So Rosa insisted on getting out of bed, and her family took the responsibility and the accountability to get her out of bed, because the caregivers would not get her out of bed because she was pretty sick and pretty weak. So the family took care of her. Now, Rosa's lucky because some of her grandchildren are nurses, and they did that for her, and they fed her and got her through. And so Rosa had a great outcome. Post-discharge, she was able to walk, she was able to take care of herself, she was able to cook for herself, and she was able to clean her room because that's very important to her. Now, she also saw the birth of her fourth great-granddaughter as well. Now, this was another dull moment for me because you see, if you haven't guessed it, Rosa is my grandmother. And I experienced this first off, and one of the things that I learned is never underestimate her, because I honestly thought that that was it. That she was pretty sick and that we were going to lose her. She had a long life. But she came back. That wasn't her plan. And so it was really important. But the other thing was that the clinical team never once spoke to her about what she wanted as they developed their plan, and not included her. And although they had a great outcome, they had a great outcome because Rosa insisted on that outcome. It was certainly not the clinical team. So this is why it's so important that we engage our patients, because it's not just about, the patients that we're taking care of. It's really our families, and every one of us will be a patient. And I think that one of the issues that we have with patient-centered care and why we're not successful in it is that we start approaching and implementing programs around being patient-centered. And it's not really a program, it's really about a state of being. It's really about the culture that we want to facilitate, right? Oftentimes, these programs fail because we concentrate on the patient. And when you concentrate solely on the patient, you forget about an important group of people, the clinical team that's taking care of that patient, right? So as we look at affecting change and implementing change and looking at how we can really create a culture that's patient-focused and patient-centered, we have to balance that out. We have to think about the clinicians as well as the patient as we're working with them. And so if we really want to make an impact and change this picture, right, what I would say to you, and one of the things that I've been saying across the globe, is think about it as I am the patient, right? And that when I'm working with patients, you got to put yourself in their place and think about how you would want to be taken care of, or how you would want your family members taken care of, if we really want to realize that change. I even would say that we should change, instead of saying patient-centered care, that it's me-centered care, because it is about all of us, right? It's about the care that we want to give to everyone. So any takeaways from this is what I would ask you is to really take your stories. Every one of you have had similar experiences that I have had, and share them with our colleagues. Share what we could be and affect that change, because we can do that right now. You can do that right now as you go and take care of a patient in whichever role you have, as a leader or as a staff nurse taking care of those patients. Thank you very much for your time. I really have enjoyed being with you.